more minutes or a few more seconds for people to come in, make their way to their seats.
On the wall, don't say it 'cause I know I'm cute. Oh, baby. Louis down to my drawers, LV all on my shoes. Oh, baby. I be dripping so much sauce, got a bit looking like Grey Goose. Oh, baby. Lit up like a crystal ball, that's cool, baby, so is you, that's how I roll. If I'm shining, everybody gonna shine. Yeah, I'm gold. I was born like this, don't even gotta try. Now you know. I like shot a nigga better over time. Now you know. They just say I'm not the baddest bitch you like. It ain't my fault that I'm out here getting loose. Gotta blame it on the goose. Gotta blame it on my juice, baby. It ain't my fault that I'm out here making
Alright, so everyone can find their seats
gotta
so we
blame
can
it
get
on my
started. That would be wonderful.
Yeah, 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 yeah. Blame it on my juice. Blame it on my juice. Yeah, 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 yeah. Blame it on my juice. Blame it on my juice, baby. No, I'm not a snack at all. Look, baby, I'm the whole damn meal. Baby, you ain't being slick. Don't dare try to cop a feel. The juice ain't worth the squeeze if the juice don't look like this. Hold up, nigga, please don't make me have to take your bitch. If I'm shining, everybody gonna shine. I was born like this, don't even gotta try. I like shot a nigga better over time. Heard you say I'm not the baddest bitch you like. It ain't my fault that I'm out here getting loose.
Alright, so I think we're gonna go ahead and get started. We want to make sure that we have a lot of time to get to all of your questions.
I'm gonna put it in a proof.
Okay. Hi everyone. I know there's so much excitement going on, but I'm so happy that you've all decided to join us for today's Breasty Breakthroughs panel. So for anyone who I haven't met yet, my name is Kelsey. I'm editor for The Peak for the Breasties, and in case you don't know, thank you. So The Peak is our all-encompassing media platform for people affected by cancer to feel empowered when making decisions about their health and wellness. So at the Breasties, making this information accessible is really important to us. I know we often say that we need to be our own best advocates, and in my experience that means knowing what we're advocating for. So having a discussion like these with panelists like these is our way of making sure that we get that information out to you. So we know that it can be tough to find this information on your own, and we are so grateful to have these amazing panelists here to join us, and we're grateful for not only the work that they do, but the fact that they're willing to dedicate their time on a Friday to come up here and share this with you all. So, how today's gonna go, each of our wonderful panelists has a short presentation where they're gonna share a little bit about the research that they do, whether it is research, surgery, new technologies that help us as a community. So here we have Kevin Musakawa representing Natera, and he will be presenting Signatera, which is a custom screening tool. I don't want to give too much away. We have Dr. Jill Dietz, who has held many leadership positions in the breast cancer and surgery spaces, but she is a breast surgeon and chief medical officer and acting president of her health startup, SciDuck Diagnostics, which she will tell us all about. We have Dr. Ann Pellet, who is a breast and plastic surgeon and the co-director of the Breast Care Center of Excellence at Sutter Health California Pacific Medical Center. And so deserving of all the applause, and she's also a member of the Breasties board, which is so lovely. We have Dr. Steffi, who you now know, and she will be sharing us a little bit more about her research. And then we also have Dr. John Klock, who is a board-certified medical oncologist, and he's been involved with many startups to improve the health of women and children, and he will be sharing a little bit about QT Imaging, a startup that he's been working with for some time, which is a novel breast imaging technique. And with that, I'm going to pass the clicker, and we will get started with Dr. Klock. Oh, I apologize. We'll be getting started with Kevin. Next is Dr. Klock.
All right, hey everybody, good afternoon. So first off, I want to thank the Breasties organizers for having me on this panel. It's a really esteemed panel, and it's really an amazing opportunity to speak to you guys about what we're doing at Natera. So my name is Kevin Masakawa. I am the VP of Marketing at a company called Natera. And over the next 5 to 7 minutes, I'm going to talk to you about a test that we have developed called Signatera. Now, Signatera is a personalized molecular residual disease test, and I'll tell you what that is all about. But what it is meant to do is meant to be able to detect whether or not your cancer is coming back. So before I talk about what molecular residual disease is, I'm going to talk a little bit about what are some of the components and how do you track it. So one of the most important pieces to track whether or not your cancer is coming back is to track circulating tumor DNA. Now, it's different from circulating tumor cells. Those in the past have had a lot of hype, and they haven't lived up to the hype, but circulating tumor DNA is different. And so on the left-hand side, I'm going to describe to you a little bit more about circulating tumor DNA. So in all of your guys' bloodstreams, you have DNA floating in your blood. For the vast majority of people, that DNA is from normal cells. As cells die and they shed. If you have a tumor, which is depicted as the brown spot there, is the clump of cancer cells, that also will release DNA into your bloodstream. Now that is termed circulating tumor DNA. And the important thing to do is be able to discern between circulating tumor DNA and your normal DNA. And technology has gotten to a point now where you can do that. And we've done that here at Natera with Signatera. So detection of molecular residual disease is identification and quantification of circulating tumor DNA in your body. And some things that you can do to help, well, what can it help answer? What is the value of identifying circulating tumor DNA? Is in conjunction with the tools that you and your clinician are using today, it can help answer these 3 critical questions. Is there cancer left in my body after surgery, for example? Is my treatment working? And you can get a real-time assessment of whether or not that treatment is working. And then finally, is my cancer coming back? All things that many patients, clinicians struggle with because the tools that we have today can be inadequate, they can be indeterminate, they may be inconclusive, they may say different things, and sometimes you need something else to help assess whether or not your cancer is truly coming back. And I know many of you in this room can have experienced that in the past. So what is Signatera and how does it work? So Signatera, you need a piece of your tumor tissue. And most of you with your breast cancer diagnosis will have your tissue. Either the pathologist will have it or your oncologist knows where to get it, or your surgeon. But Signatera will design a test off of your tumor tissue. And it will identify the things that really make that tumor unique. And we like to call it a fingerprint. So just like each one of you in this room has a unique fingerprint, so does your tumor. And being able to identify that fingerprint for that tumor enables you to track that tumor over time. And so the middle bucket is then with that fingerprint and that knowledge of what makes that tumor tick, for example, you'll be able to then track it over time. And on the far right-hand side, you'll see that this test is a longitudinal test, or with serial blood test, you can assess whether or not there is ctDNA in your bloodstream or not. The test for Signatera is easy to understand. Right? So if you're positive, it means that ctDNA is detected in your bloodstream. And in other words, what that means is your cancer is likely to come back. If it is negative, like the vast majority of our tests are, it means that ctDNA is not detected in your bloodstream and that it's unlikely that your cancer is going to come back. Now, we shy away from words like, oh, you're going to be, you're cured, because no test is perfect. Right? So this is why we say in conjunction with the other tests that your doctor may use, this is another tool and more information for you to understand your cancer. Many clinicians don't know about this yet, and we're still trying to educate many clinicians, and we're trying to educate patients as well, so they can advocate for themselves if they think this test is right for them. I will stress the importance of the patient-clinician consult is really, really important, because this is a really powerful tool that some patients and clinicians don't necessarily always want the information, because they will say, well, what do I do with a positive test? And that's ultimately up to you and your clinician to decide whether or not this test might be right for you. This is a very busy slide, and I apologize for you in the back who can't see it, so I'm just going to touch it on a high level. Is that Signatera is not something that is just made in someone's garage. We actually have been published in many peer-reviewed journals. You know, in each of these kind of vignettes, you'll see colon cancer, breast, lung, and bladder. In each of these, we've published papers to show that the test works. And the graphs, well, I won't get into a lot of detail, but on the x-axis is time, and on the y-axis are the number of people who will recur or relapse. And as you can see, if you're on the green line, if you're ctDNA negative, you tend not to recur. And if you're positive, your chance of recurrence is a lot higher. In fact, in many of our studies across different tumor types, if you are ctDNA positive, without additional therapy, you're almost 100% likely to recur. Again, as you can imagine, this is a very powerful tool where, again, it can augment the tools that you are currently using today. But the important thing to notice here is that there's consistency across different tumor types. You know, we have Medicare coverage in colon cancer, recently got Medicare coverage in breast cancer, Medicare coverage in muscle-invasive bladder cancer, and for immunotherapy monitoring, and we're working on lung cancer as well as ovarian and other cancers as well. Those are to come. But the body of data continues to build, and the consistency of results is something we always see. So my last slide here, is Signatera right for you? So again, you have to have cancer or have had cancer yourself. And this is for high-risk breast cancer patients, stage 2B or higher, across any subtype, triple negative, HER2 positive, HR positive. We say high risk because if you're low risk, and again, risk is, you ask 10 doctors about risk and everyone will say a different thing, right? And again, that's a decision for you and your clinician to make. We say high risk because if you're low risk, we don't want people getting a bunch of negative tests because then people will say, well, why am I taking this test? And we don't want to incur a lot of costs in the system. So typically, these are people who are concerned about their cancer recurring, and we typically term them as high-risk individuals. If you and your clinician are trying to understand, do I have cancer left in my body? If you and your clinician are trying to understand, is my treatment working? Or trying to understand, is my disease coming back? Signatera might be right for you. I have a quote here from an actual Signatera patient who actually talks about the power that Signatera can give you. And this is power of information, the power of knowledge that helps her plan. In case the tests are positive, she knows, and she's had this conversation with her oncologist, of what that might mean for her. If it's something that you might be interested in, talk to your doctor about it. I will be around here for the next day or so, so please do come up to me. I look forward to meeting as many of you as possible, but thank you for the time.
Thank you so much, Kevin. That was really great. So now we are going to pass it over to Dr. Clock, who will tell us about QT imaging. Thank you.
Great. Nice to be here. Several people came up to me while I've been here and said, tell me about your breast cancer. Well, I said I could have it, I might have it, and men do get it. And we see a lot of men with BRCA. We see transgender women. So talk about groups that don't have any support. That is a big one. So think about that. Medical imaging is the #1 thing that doctors need to make you well. And it's huge in breast cancer. It can tell you where it is, whether you have it, how the treatment's working. So all medical people use it. And the problem with breast cancer imaging is that it's challenging. And the reason is because the breast is the largest sweat gland in the body. It's a modified sweat gland, and it's all glands. So very hard to see. So we're going to talk about something that we developed with the National Cancer Institute to solve some of these problems. So it's 40 times the resolution of MRI. We'll show you why. The National Cancer Institute also gave us $20 million to develop something that was 100% safe. It uses sound wave just above the spoken word, and it uses transmitted energy, not reflection. There's no radiation, there's no injection, there's no compression. It's very inexpensive. And 2/3 of the women in the world have no breast imaging. Are you aware of that? So this is a huge need worldwide. Minority women also don't get screened, so this is an answer for them. We're putting a clinic in Uganda next month. We do have FDA breakthrough device designation, which is specifically designed for women who are young, who don't qualify for the mammogram, but who have a high risk. So if you're one of those women. So anyway, why do we need another breast imaging technology? Well, we need to detect really small cancers, and this can detect those BB-sized cancers. We need a solution for dense breasts. We are approved by the FDA for dense breasts. There's really no screening available for high-risk younger women. We've scanned women as young as 18 who have breast cancer. We need a solution for false positives because a lot of the tests like MRI do have a high degree of false positives. And we need to really do something to replace some of the traditional cancer paradigms that are out there. For instance, in Uganda, if you're a woman and you have a breast biopsy, you are socially excluded from the village, you have to go live in a hut, and you usually die. This is a big problem in all of Africa, and this is one of the reasons that we're putting a scanner there. Well, why is it 40 times better than MRI? Just to make a long story short, we have 200,000 times more data than MRI. We also look at the breast spot in your breast from 1 billion different vantage points. So this is hugely sensitive. We're making a breast scanner for newborn babies, okay? And this is the lung of a pig on the left, a piglet, a newborn piglet with an MRI. You can see the lung is black. There's no data here. If you look at the QTs on the far right, you can actually see the alveoli of the lung. These are the little air cells. They're smaller than the size of a human hair. So this is really nice technology. And we can see all the tissues in the breast. So this is something that has never been seen before. So we can tell what's there. This is a 3D printed model, and if you'll hit the space bar on the computer there, it'll probably start. This is the only technology in the world that can generate a 3D model of the breast duct system in a living woman. So this is very important because if you have healthy breast ducts, guess what? You're healthy. That's where most of this cancer develops. Sorry that the slide doesn't work. So this shows what a QT scan looks like. On the far left is a QT scan. This woman came into the clinic for screening. We found the cancer in 4 minutes. Her doctor said, well, I've never heard of this. This is crazy. You need to have a mammogram. So she had a mammogram and a digital breast tomosynthesis. The next one was negative. Then she had a handheld ultrasound because she said, I do feel a lump here. They found the cancer. Then they did the MRI on the far right with gadolinium. All of this took her 6 weeks, cost her $3,000 out of pocket, and, you know, really was challenging for her. So this is the technology that can replace everything else in breast imaging. What else can it do? Well, there are two kinds of cancers. There's the kind that kills you and the kind that doesn't kill you. Why is this important? Because some women have breast cancer that will never kill them. It's called non-invasive breast cancer. So we are approved by the FDA to do doubling times. We're 99.9% accurate. We can tell within a few weeks whether you have the cancer that's going to kill you or not kill you. So if you're an older person and you have breast cancer, you might have the kind that will never kill you. So I have a good friend. She's 85 years old. You know, she was diagnosed with this non-invasive breast cancer. It's never going to kill her. So she has a different plan of treatment for herself. So this is very important. The other thing about this technology, this is our scanning center in north of San Francisco. You can see it's not a clinic. And one of the advantages of this technology is you can wheel it in anywhere. We have these things in office complexes. They don't need to be in a hospital. You don't need a technician that's trained in ultrasound or anything else. So this is really important because one of the things that women need is more control over their bodies. And one of the things we've scanned over 15,000 women, and guess what? The incidence of breast cancer is much higher with this technology because it can see through the dense breast. But I think you all need to understand that your experience is power. You're telling people what's happened to you, and that's a power that you can use. And one of the things we are doing is trying to get women to open direct-to-consumer facilities so you can have one of these in your community if you get together and do it. So I just hope that you all will think about that. And I have some brochures I'll leave up here. Contact me anytime you like. Oh, one final thing. The best possible news is that the largest medical device maker in the world just signed 2 contracts with us last week for worldwide distribution of this technology.
What exciting news. Thank you so much, Dr. Clock. And now we will pass it over to Dr. Dietz.
Thank you. I'm super excited to be here and honored to be on this panel. And I had to come all the way from Ohio to see one of my favorite patients, Asha. So I got to get a hug. So, I have a really exciting PowerPoint presentation that after going to the fireside chat last night and listening to those amazing stories and hearing the amazing stories this morning and listening to, people that I've met like Kennedy and Paige and Asha and Yahira and many of you, I decided to bag that, do a Trish, pivot, and tell you a story. Okay, so I am a breast surgeon, but I'm also a caregiver. I lost my grandma and grandpa, and my mom has cancer now, and I lost my best friend, my brother. To cancer, I'm sorry. I don't know, I don't think it's hormones. Anyway, that my brother was 31 when he told me, he called me and he said, I have this cough and I have my scrotum swelling, and I said, you're a vet, you work with animals, you probably have allergies, you probably got a hernia from your coughing. He's like, yeah, but my eyelashes are like 1 inch long. And I was like, whoa. So he made an appointment for 3 months later, and I was like, no. And luckily, he pulled some strings, and he got in, and he was diagnosed with adrenal cancer. And I was like that pregnant. So I had to drive from St. Louis because I wasn't allowed to fly, and he had an 11-hour surgery. 3 surgeons took out his kidney, his adrenal gland, part of his diaphragm, part of his big vein. It took 11 hours, and the surgeon never talked to us. I was stunned. At the end of the story, his medical oncologist pulled me into the recovery room and said, you can, go see him. So I got to see him, and he said, time to cowboy up. And I was like, that's right, it is. And we got to spend a lot of, weeks and months together, and then he passed. And that, I didn't have cancer, but it changed my life forever. And I was a different person after that. My priorities were different, and how I interacted with my patients was different because I understood. But I do want you to know that your doctors do care tremendously about you, and they want what's best for you. But sometimes we're human and we just don't get it. So advocate for yourself. That is why, as a surgeon, I'm teaming up with Dom and SIDAC, because I want to make a bigger difference. I miss my patients a lot, but I want to make a bigger difference. And after listening to you, I've heard, okay, so you're saying that you knew something was wrong with your body, but nobody would listen. And you're saying, I have this genetic abnormality, and I know I'm very likely to get cancer, but I don't know when, and I don't even know if. Or you're saying, I have super dense breasts, and I'm really worried that my mammogram is going to miss my cancer or has missed my cancer. So what if there was a test and you could do it at home? And that test took fluid from your nipple and looked at the biomarker profile in it and could tell you, you're fine. It's the way it always is. Or, no, there's something going on here. You have a problem. You need to get in and see your doctor, and you need to do additional testing. Maybe that cool thing that you have. That's awesome. So that's, what this test is, okay? It's called Be First. And what we're doing is you get this kit at home, you can get it on Amazon, you might be able to get it in your doctor's office. And we know that in a lab or clinic setting, 95% of women, we could get a little bit of fluid out. So we have to translate that into a home test. We also know that in a laboratory setting, these 3 markers predict cancer, okay? These biomarkers predict who has cancer. So if we can combine that at-home test with this laboratory test, we can, with very good success, tell you that you're at immediate risk. Not like, I don't know when, maybe you will, but you can follow and monitor your breast health. So this is just a schematic of how it could work, but essentially you can monitor your breast health with this at-home test. So really what we want to do is we want to empower you to take control over your own breast health and your breast risks, and then work with your healthcare team to be able to know what's going on in your breasts right now, a temporal assessment. So in the future, we want to establish a large registry where we can put risk profiles and biomolecular profiles together with your information to help each person utilizing this have a better understanding of their risk. We want to actually introduce this biomolecular risk assessment into the clinical screening process because it does not exist right now. And then we want to put what we know works in a clinical setting and in a laboratory setting into the hands of individuals to help take care of, empower patients to do that. So thank you, and if you want to help us do this, because we're very early, please contact us, and we'd love to put you on the list. Thanks.
Thank you so much for sharing, Dr. Dietz. We really appreciate you sharing your story. And now we'll pass it to Dr. Steffi to tell us more about the research that you are doing. Thank you.
I am so happy. Can you hear me? Yes. Is it on? I am so happy to have the microphone again. So I decided, the name of the panel is Research Breakthroughs. I'm going to share one breakthrough which I think is truly phenomenal, what has changed outcome of thousands of patients. Then I'm going to share 2 research projects which we have ongoing in the lab, which I'm very, very passionate about. And then I will end with one story where I think we would like to study more, and that's a research project which we are just starting in the lab. So the first one of the breakthroughs I think is really over the last few years for HER2 positive breast cancer. I think outcome has tremendously improved with new therapies, and they're called, the drugs are called ADCs, antibody drug chemotherapy. So basically you take chemotherapy and conjugate it to an antibody. There are a couple of drugs out there, TDM, TDXD, more, and they can bring the chemotherapy with very high affinity in the cells. The clinical trials have been absolutely stunning. It really has changed outcome for patients with HER2 positive breast cancer. This is the first time ever that in the metastatic setting, we talk about curing patients, right? This hasn't happened before. So there are now trials in discussion where actually, at the moment, once you have metastatic disease, you just take therapies forever, right? So now there are trials in discussion where you take these novel therapies and actually, then compare actually coming off therapy and see if you are cured from the disease. So again, I think these new ADCs therapies is an absolutely breakthrough. I think this has changed outcome. We hope that, and there are a lot of companies working on this, and obviously in conjunction with the researcher, with the academic institutions, to have similar ADCs also for estrogen receptor positive breast cancer and for triple negative breast cancer, But this is a revolution, the revolution in breast cancer therapy. I think we are super excited about this. It will clearly, keep your ears, eyes open. I think you will hear a lot more about this. It's super, super exciting. It's a breakthrough. And I should say, every progress in outcome for patients with breast cancer comes from research, right? Everything starts in the lab to figure out things and then develop it into new drugs, develop it into assay and liquid biopsy, develop it into new surgery approaches, transform it into different imaging approaches whatsoever. But research brings the change, yeah? Okay, 2 research projects which we have ongoing in lab, which I'm tremendously passionate about. So the first thing, I should say, it's a little bit of a sensitive topic. The first thing, we call the project Hope for Others. It's actually a project which arose out of our focus on stage 4 disease, on metastatic disease. We can only make progress in understanding and treating metastatic disease if we have access to tissue. If we don't, we will never understand it. So one of the projects we started, and again, it's a sensitive topic, but I think that I can bring this to you here, is when patients consent to donate their body at time of death. It was previously called autopsy. Us realizing that such a sensitive topic, so we paired up with patients and patient advocates and asked them, how can we do this? I mean, how do you feel about it? And the first thing they said is, ooh, don't call it autopsy, right? That's not a good start. And the patients and the patient advocates actually came up and said, let's call it something else. What we would like to call it is hope for others, because that is the ultimate gift, and hopefully something comes out of that for the next patient, right? So we have this program ongoing. We are tremendously grateful. Like I said, this is the ultimate gift. Tremendously grateful for patients, for their families. But what it has allowed us is to sequence metastatic disease and understand why, if a patient has the same stage grade of disease, why in some cases you have a few cells laying in the brain and they don't do anything. They never grow, right? They are there. We call this dormant. They are dormant, they are asleep. And then another patient, unfortunately, they start growing, right? So we can take the tissue, we can sequence it and truly make progress. So there are other institutions which now have that. That Hope for Others program is something which is driven by the patients, and we are super, super grateful to them, to the community. And it's one of those projects where we as researchers feel tremendous responsibility to make the absolute best use of those tissues, to use state-of-the-art approaches. And I think what's also very important, and sometimes I think patients think that the researchers sit in their little corner and don't talk to each other, and I think collaborations is critical. Everybody has, different ideas, different approaches, so we collaborate with many other institutions in the US, but also international, to really then, like I said, make the most of that tissue, of that gift given to research by the patients and their families, yeah? So this is the Hope for Others program we have ongoing. The second project I'm very, very passionate about is to understand breast cancer heterogeneity. So, every tumor is different. I think there's a lot about precision medicine. Kevin talked about this, is that we really need to understand different tumors. One of the tumors which we study a lot, which I think has not been recognized as an independent disease, is something called lobular breast cancer, invasive lobular breast cancer. I think in the past, and still very often now, it's just lumped together with ductal breast cancer, just said, okay, it's yet another ER-positive tumor. But clinically, they are very different. The hallmark of lobular breast cancer is loss of a molecule on the surface of the breast cancer cells. It's called ecdyterin. It's like glue. It makes cells stick together. If there's a lobular cancer, the cells grow more in a string, and as a result of this, it's not picked up by imaging that well. The tumors, they're picked up later. The metastatic behavior is very different. It goes to like more unusual sites, like the ovary, peritoneum, the GI tract. So we really try to understand what's different about the disease. We work a lot with patient advocacy groups for them, again, to tell us what's important to you, what should we focus on. Actually, I want to make a plug. This year in September, there's going to be a really big meeting where all the leading groups nationally and internationally studying this disease will come together in Pittsburgh. We have, again, we work a lot with patients. We work with you guys to really drive our focus, our research. The same for the meeting. We have an organizing group of patients, patient advocates, who organize part of the meeting. You can find it online. You know, Google ILC Symposium 2023. If anybody's interested, join us. So very, very passionate about heterogeneity, specifically lobular breast cancer. And I want to end with an area we just started. We just published a large paper on this to really understand the role of the immune system in ER-positive breast cancer. We have made progress in triple-negative breast cancer. There have been, actually I should say, there's been tremendous progress outside breast cancer. Melanoma, lung cancer, immune therapy really has made a lot of progress. In breast cancer, a little bit, at this point in time, mostly in triple-negative breast cancer. In ER-positive breast cancer, we have just made very limited progress. So that's an area I think needs more research. We don't understand why the immune cells don't go more into the ER-positive breast cancer, why they are mostly what we call them cold. So I think for us to understand, to study this more, is critical to be able to use the power of the own body to stimulate the immune cells to fight the breast cancer. So that's a topic we would like to get more into it, because I do think it is very, very important. And again, I want to end with saying I'm tremendously honored to be here. I congratulate you to be here, to form these communities. I had a blast swimming this morning. And, maybe I can just make sure that I'd love to come back, so.
Thank you.
Thank you so much, Dr. Steffi, and thank you for plugging the ILC Symposium. I know we're always looking for more ways for patients to have their voices heard. And so I will pass it off to Dr. Pellet to share breakthroughs in surgery.
Thanks, Kelsey. Thank you. Just so excited to be here. I get to talk over rooms with people all the time who get the breast cancer surgeon part of me, but I so rarely get to be in a room with people who get the breast cancer survivor part of me and really get what it's like to be Worst Club Best members. So it feels really good to be giving a talk to all of you who really get it. So this is going to be a bit of a whirlwind, but I think one of the things I see over and over again is you don't know what you don't know, right? And so unfortunately, a lot of us, we get offered things that our doctors have in their toolbox, and it may not actually be what is the most advanced and most cutting edge. And so I want this to be, you may not need it now, but you may need it at some point, and also advocate for yourself. You hear this over and over again. You're the only one who wakes up in your body every day, so you get to ask for these things. You get to ask for better. So these are kind of some of my favorite things and kind of what's going on. So lymphedema prevention, expanding options for nipple sparing mastectomy, and then sensation preservation and kind of avoiding nerve pain. So, you know what, I'm going to come right here, if that's okay. So, starting off, thinking about lymphedema. So, we know that lymphedema rates can be really high if you do need an axillary node dissection. This can be worse if you need radiation. And so, one of the things we're trying to figure out is, can we proactively prevent lymphedema? So, rather than going back after the fact to treat it, which can be difficult. And there's actually something called a lympha procedure, some of you may have heard of, but I have to say I'm really impressed with how many breast surgeons are taking this on in their practices and working with microsurgeons to add this. So essentially what a lympha procedure does, it's a lymphovenous bypass. So if you're someone that's having an axillary node dissection, you're having many nodes taken out, what we actually do is can channel around the areas, figure out which lymphatic vessels we can preserve, still take the lymph nodes we need, but instead channel these lymphatic tissues to go through vessels and go through veins. And what that can do is it can actually decrease the rates of having lymphedema after the fact. But what's really important is that this is done at the time of our lymph node dissection. So we have great options for going back after the fact that continue to evolve, but this is really a proactive solution to preventing lymphedema. However, what I'd like to think of is even trying to go one step further is trying to figure out, can we even avoid axillary surgery at all? And so one of the great things that we're all working on, and Dr. Dietz has been involved in this research as well, is usually people who have DCIS or other what we think of as non-invasive but higher risk lesions are actually told that they need to have lymph node biopsies at the time of mastectomy. And the reason for that is that in some number of cases, when you have your final mastectomy pathology, you're going to find invasive cancer, and it's very difficult after the fact to do a sentinel node biopsy. But it turns out that that only happens in about 15 to 20% of patients. So essentially, we're doing unnecessary lymph node surgery for 80–85% of people with DCIS or high-risk lesions. So we have what I think is really, truly game-changing technology now, which is actually using something called MagTrace, which is by a company called Endomag, and you can do a delayed sentinel node biopsy. So I now offer this to all of my patients having mastectomies for DCIS, because what you can do is you put it in at the time of mastectomy, you don't do the lymph node biopsy, you wait to see the final pathology comes back, and if there's no invasive cancer, you're done. You don't have unnecessary surgery. In that 15 to 20% where people do have invasive cancer, the tracer stays on lymph nodes for 30 days, which is different than the typical tracers only staying for 24 hours. So now we have 30 days to go back, do the lymph node surgery to get the staging information. So again, this in my mind is so incredibly game-changing. I had personally went through lymph node surgery myself, ended up having to have a fluid collection that had to be drained multiple times. Lymph node biopsies hurt. So it actually does matter if we can avoid even sentinel node biopsies. The next one is nipple-sparing mastectomy. It's so great seeing my patients in here, and you know a lot of you will say, I feel very strongly, if it's possible and it's something you want, to try to offer nipple-sparing mastectomy. And I hear all too often that people are told either because of their breast size, their breast shape, what their tumor is, that they're not able to have nipple-sparing mastectomy. And again, a lot of this is really just someone not having it in their toolbox to offer. So more commonly what we'll do is we actually do a staged nipple-sparing mastectomy. So if you have larger breasts, you have droopier, what we call ptotic breasts, you can actually do a breast lift or a breast reduction first. You can take out the cancer. If you have cancer, you can do it in a prophylactic setting, and now you become a candidate for nipple-sparing mastectomy in a way that's safe with minimizing the chance of having any nipple complications. So again, I see people all too often who haven't even been offered this because their surgeon hasn't thought about it or doesn't know, but truly this is a great option when I try to advocate for people a lot about if you are thinking about nipple-sparing mastectomy. And then the last one, we're actually having a panel tomorrow. I'm going to be on with Dr. Bank, and I hope all of you will join that. But this is very much my passion that gets me out of bed every single day, excited to go into work, and really is thinking about how we preserve sensation at the time of mastectomy. And traditional mastectomies cut through all of the nerves to the breast, and most people do lose sensation after their mastectomies. But what we know is now we're actually able to, and it's really exciting. I just gave a talk at our major breast surgery meeting, and 20% of the surgeons in the audience said that they're starting to do this. So it's coming. It's really happening that people are going to be doing sensation-preserving mastectomies. So it's been really exciting to see how that's happening. But really in this way, these things continue to evolve. So people who've had mastectomies in the past, we're actually now doing a better job figuring out how to reconstruct nerves if you've had mastectomies previously, both with implants, flat closure, flaps. So all of this is coming, and it's really incredible technology. And then the final thing that a lot of people think there's sensation loss, but don't always associate actually injuring nerves with pain. So chronic mastectomy pain syndrome is unfortunately very underdiagnosed. It's a huge issue. And Dr. Bank, you'll hear about this some more tomorrow, but really we know that if we can avoid injuring nerves, that's the best way to do it at the time of mastectomy. But now with better nerve technologies and techniques, we actually can go back after the fact, figure out ways to deal with the scarred-in nerves and reconstruct them. So again, I think really there's so much that's happening, but again, just keep in mind that people offer what's in their toolbox, and you always have the option of asking what else is out there and be referred for better, because we all deserve that.
Thank you so much. I know I've learned so much from these presentations, but I want to ask you all a few more questions, just to learn more about how we could take all of these novel innovations and see how we can use them as patients, how we can better our patient experience. So one through line that I sort of caught on to through all of your presentations, despite the fact that you all work in different areas, is that the ultimate objective is to prevent disease, catch disease early, and offer better treatment options. So I am curious to know how did you end up where you are, researching what you're researching, doing what you're doing? And are there ways that you see the work that you're doing complementing work of other folks on the panel? So I'm happy to throw to anyone. Jill, how about you?
Sure. So I think the answer is, how I got here is I always was very interested in trying to move the stage of disease upward, because we know that early detection saves lives. We know that not all patients are either able or have successful breast screening, particularly in other countries. And I guess I just wanted to join a team that felt strongly about the fact that we wanted to empower individuals to take control of their breast health, and hopefully prevent a lot of cancer, and if not able to prevent it, move that disease stage much earlier, where survival is a lot higher and people do better. When I look at what's going on in the world of research, I really think it is a collaboration and a team effort. It's not going to be one thing. So, I look at John's really incredible imaging technology, and I think, pairing up with that is going to be important, and something that we want to do. I just gave a webinar for Cancer IQ yesterday, and this is a company that really helps centers with their high-risk patients. And I think it's going to be collaborations across multiple institutions, researchers, that's going to make us all win. So.
I'll mention something. So, before coming to Natera, I was working at a therapeutic company, as many of you know, called Genentech. And during that time when I was in oncology, people would talk about precision medicine a lot, but not really doing a whole lot to advance the field, because they were all in therapeutics. And their theory was treat until disease progression, or treat to a certain number of cycles. And we always thought there was something more that we should be doing. And that's why Natera and this test was more interesting, because as Dr. Steffi said, that not every patient needs always all that therapy, or if that patient is not responding, perhaps you should go on to something different, and catching it early and moving on earlier is something that we should be doing. So, coming to Natera was something that I thought was interesting, and how I got into the field of kind of looking at biomarkers. How we can all work together, I think there's a lot of great technology. I mean, one thing is important for people to realize, that there's technology up here to catch the disease before you actually know it, catch cancer before you know you have cancer. And then there's other technologies like what we're doing at Signatera, where once you know you have cancer, to understand whether or not that cancer is coming back. But regardless, I think there's a lot of areas where these different technologies can all work together.
Yeah, I think I would add, one of the things that I feel is very common through all of this is this concept of, we hear a lot of this term shared decision making, but really in my mind what that means is that as patients, we get to know what our options are, what our goals are, what our actual risk is, and make real decisions in the context of all of that knowledge, right? So trying to figure out how you're going to make a decision about if you should have a prophylactic mastectomy if no one knows enough about your genetic mutation to know when or if you're going to get breast cancer ever or is really difficult, right? And so I think what you're hearing from all of us is you get this information, right? You get to have things. I personally test myself with Signatera every 6 months, and it's really scary, honestly, but I like knowing that, like Kevin said, I have that information, so I get to make a decision about my personal risk, thinking about screening, thinking about what kind of tools you're going to use, and I think there's no way that any of us can make informed decisions if we don't have as much information and get to be using that for that conversation with our physician. So I think for me, that's what I see a lot of, is really that idea that we're getting more comprehensive information.
Yeah, like I mentioned earlier, we do work a lot on liquid biopsies. We do think that is the future for, prediction, looking at response to therapy. We do actually currently have a clinical trial with Natera. Kevin, you might not even know because the company is so big. So anyway, there might be somebody else who's directly working with us where we look at changes in liquid biopsy over time. And this is done, we talked about underserved communities earlier, right? So for that trial specifically, the patient doesn't need to come to the clinic. There's a mobile phlebotomy lab which drives out to the patient's house because, again, you don't need to have a biopsy, you just give some blood. And it is, especially not everybody has a car, or you don't need to pay for parking, or whatever it is, right? So this is relatively easy. And I think that's where, for example, our research group works together with Natera to drive the use of liquid biopsies forward. Actually, one story I want to mention, when I was a student and I wanted, to become a professor and do breast cancer research, there wasn't that much interaction between academia and pharma. Indeed, when somebody left from the research lab, I do remember people saying, oh, I go to the dark side. And I would say that has tremendously changed. I think now there is so much hand-in-hand collaboration between folks in biotech and pharma and academia, where both sides have realized you need to work together to move things forward. Over my lifetime as a researcher, I would say it has totally changed, and it's very, very exciting. So there's a lot of collaboration.
Well, I think it needs to be said that I believe that breast cancer will be cured in the next generation. And I say that because of what you see here and what I know that's going on in chemotherapy, and I do believe that your daughters will be facing a completely different world than we're facing today. But to answer how I got into this, my wife Cynthia's back there, and she is the head nurse of the cancer center at UCSF at one time, and she came up to me and she said, there's a story about these monks that were sitting in by the riverside, and they saw these bodies keep floating down the river. And they were sort of curious, why are these bodies floating down the river? Well, she and I felt like, we're talking 10 years ago or more now, felt like that's what we were doing in the cancer ward. We were seeing these people later and later, and it's very hard, very hard. So what the monks did was they went up the river and they found out why the people were being pushed into the river, and they stopped them from being pushed into the river. So we worked for 10 years. We imaged 10,000 people with high-resolution whole-body imaging, healthy men and women, age 50. We picked up 500 cases of cancer, and they're all cured. So what that told us was we have to go upriver and detect these things. So the kinds of technology you see here is really, really important, because if you have a really teeny tiny cancer, it's highly curable. So I would just encourage all of us to think about that and think about the things that we can do here to really detect this earlier so that people don't have to go through what a lot of you went through.
Thank you all, and thank you, Dr. Clock, for that, because I know selfishly, I'm putting my cancer patient hat on. I'm thinking, how can I go up the river for my own care? And I'm sure it's a thought that many of us here have, is these all sound like amazing breakthroughs, but then we get to that question of how can we access them, or how can we advocate to use these innovations in our own care? And especially if we're looking at underserved communities, communities where we know cancer tends to be caught at later stages, where diseases tend to progress much more and have worse outcomes. How can we take advantage of everything that you're sharing with us today for the health of our communities?
I mean, I think a lot of it honestly starts with everyone in this room. So the reality is, if all of you are out there talking about advocating for better, talking about new technologies, talking about that's how people hear, right? You hear all these stories of everyone finding themselves in these communities, but honestly, I think so much of this becomes patient and community driven rather than coming from all of us as physicians and researchers.
I agree. That's why we're in this room and not at a large academic conference.
I would say something that Anne had said earlier is ask questions. What else is out there, doctor? What else can I be doing? Because Signatera is available today, but just many doctors don't even know about it. You just need to ask the right questions.
Take control of your health. Now is the time.
I would also say that, you know, if you have the ability to join the time, the resources, if there are folks around you with advocacy groups, if you can join them in at your local places to advocate for research, for better education, change legislation, whatever. But I think if you're willing to do that, a lot changes comes from the breast cancer advocates. So if you can join groups, it would be fantastic.
Thank you all. I think we might have time for a couple questions from all of you. Before we get started, I would just like a couple reminders. We have an amazing group of experts, and while they are medical professionals, they are not your medical professionals, so they do not know your case. So I'd recommend keeping your questions as general as you can. And as we mentioned yesterday, please try to project your voice as much as possible so that we can make sure everyone can hear your question. I saw a hand over here, very eager.
Just a small background in my fears. I was diagnosed 2018, metastatic breast cancer with metastasis to bones. And then I went through treatment and I said, yay, I'm not gonna think about this anymore. Well, in 2021, I was diagnosed again with triple negative, both times are triple negative. And I said, what? It came back. Why didn't I know that this was something that could come back? Then my fear now is it coming back again? Or are my daughters, I have 3 daughters, are my daughters ever gonna get this? And I hear about the QT scan, and I'll say, well, can my daughters get that right now? But because my genetic testing came back with nothing, how can I, because I asked my oldest daughter, she's now 33, can you get tested? And she went to her gynecologist and they said, no, you cannot, because your mom didn't, there's no, well, yeah, she can't. How can I access any of that for my daughters? And my other question is, does insurance pay for it? Because that's a biggie on everything we do and all the treatments that we get.
Thank you. Dr. Clark, would you like to respond?
Well, we have breakthrough device designation from the FDA specifically for this. So women who have a cancer gene. Of course, most women with breast cancer don't have a gene that we know of. So if you have a history in your family, then that is also qualified you for high risk. So we do have 8 centers. We're putting in 6 more in the next couple of months. So it's happening. But if you want one for your locality, come get one of these little things and talk to me, and we'll make it happen. We give free scanning to people that can't afford it. But by the way, if you come to our center, it's $300 to get a breast scan, and there's no cost for the callback. It's free. So it's very reasonable. The co-pays for traditional imaging are usually more than that. So we are certainly willing to help you.
Thank you, Dr. Koch. Over to you.
Hi. So I have 2 questions, and feel free to only answer one. One is about the Signatera blood test, and then I'll ask that first. I'm super curious about this. I've asked my doctor about it, and they've been like, well, it's very high or false positives, all these things. But I would love to hear more about how I know that we can push to advocate for it, but insurance rejected it. So I'm really curious as to where that's going and how we can talk to our insurance about getting that. And then the second one is about, I'm hitting my 4 years post in remission, however you want to call it. And 2 of my oncologists have said, well, once we hit 5 years, we don't have a lot of research or, evidence post. I'm like, well, we're in 2023. How are we still getting those answers from the doctors saying, post 5 years, not a lot, it's your choice, quality of life, all this stuff. But for me, I'm like, I know that there's research out there post 5 years. So those would be my 2 questions, is about the Signatera, and then post 5 years, what does that look like? And how can we ask our doctors, hey, what's happening post 5 years?
I'll tackle the first one on Signatera. Great question, thank you. So we are all ahead of the curve here right now, right? So we have Medicare coverage for breast cancer patients stage 2B and higher. Your doctor's right, we do not have commercial coverage right now for Signatera. Right now, most commercial coverages will flat out deny the claim. And Natera right now is not going after the patient or asking for any payment back. Because most of this, we call it non-covered services, we do not charge the patient anything. In the event where there is some small copay because the insurance company will cover a little bit, Natera will have patient assistance programs. Now, I can't speak broadly about it because every patient's program will be a little bit different, but usually what we do is if you're on Signatera and you looks like you have a copay that might be larger than $149, which again is not usually the case. The vast majority of patients won't owe anything because again, most commercial providers will flat out deny us and then we don't go after the patient. That is evolving, that is changing for the better as people start to know more about Signatera. We're asking advocacy groups to talk to within their states because there's a state biomarker bill that is being passed with state by state to say any biomarker that is covered by CMS should be covered by commercial payers as well. That is also evolving and is happening. So my short answer to you is that even though it's denied by commercial insurance, you can still get it. There's no reason why you can't get it, right? And again, we should talk offline and I can tell you about some things that we have at Natera to help you out.
Do we have time for the other question, or do we? Okay, so I can answer kind of the 5-year question. So I think there are a couple different pieces to it. The first one is thinking about what kind of treatment do you need? And so for hormone receptor positive disease, we actually have good studies on 5 versus 7 versus 10 years of treatment. And also we have testing now that we can do that gives you a sense of whether or not you would benefit from extended hormonal therapy. So that's when, if you have hormone receptor positive disease, I always recommend talking to your oncologist to see if 5 versus 10 years makes sense. I think, so that's kind of the treatment piece of it. The screening piece of it, we do know, again, we are now wonderfully going to have things like Signatera to actually monitor for recurrence, but we actually don't recommend in people with lower risk disease that there's an ongoing screening on a kind of full body way. There's breast cancer screening, of course, of the breasts themselves, but I agree that's kind of a tricky place to say we kind of just wait for symptoms, and I think that's exactly why we're trying to do things like have these biomarkers so that we can do that. But certainly we do know that screening still is important from a breast standpoint, monitoring symptoms closely, thinking about biomarkers, and then thinking about length of treatment. All those are the kind of things that we think about as we go beyond 5 years.
Thank you. I think we have time for one more question. Perfect.
Hi, my name's Emily. Dr. Pella is actually my doctor. She's amazing. And I have about 90% feeling in my breasts after getting surgery from her. I actually found out about her technologies and surgery from the breasties. So that was why it was so important, I think, for all of us to share stories. I actually have 2 questions. So the first one, maybe Dr. Pella can answer, is for people that feel in the future that they may, not want to have implants forever or get explanted after nerve preservation surgery. Is there an option to still preserve the nerves if you are, opting to maybe go flat in the future or having some type of new flap surgery done after you've been explanted? And my second question is, as a BRCA1 carrier who is also seeking out a hysterectomy, if there is any technology right now that is on the horizon for better screening methods, because right now I'm, every 6 months I'm getting CA125 tested and I'm getting internal and external ultrasounds, but even my doctors and oncologists have just told me that that's like not really doing anything. And it's something that's not really going to be found until it's already later stage cancer. So what kind